All right, good morning, everyone. Welcome to this informational webinar about the National Pediatric Practice Community's Pilot Site Program. We're excited to share this information with you. A few housekeeping items before we get started. Everyone on this webinar is muted. Please use the chat function to ask questions. We will ask questions. If you want to chat during the presentation, that's fine, and then we'll answer your questions at the end. The recording of this webinar will be posted on the NPPC website within the next week. With that out of the way, let me introduce myself. My name is Molly Peterson. I'm the program manager for the National Pediatric Practice Community. And with me today is the director of the NPPC, Lena Singh. You might hear some other voices on today's call. These build out the rest of the NPPC team that oversees the pilot site program. Carissa Luckett is our amazing coach, working with all of our pilot sites to shepherd them through the process of setting up screenings. Sarah Marks oversees our program as the director of strategic initiatives. And Kriya and Lisa help us evaluate the progress of the pilot site program. Here's our agenda for today. First, I'm going to give you a quick overview of the National Pediatric Practice Community, also known as the NPPC, and the Center for Youth Wellness. We'll do a primer on ACEs science and then dive into the details about the pilot site program and the application process. And of course, answer your questions at the end. The Center for Youth Wellness is part of a national effort to revolutionize pediatric medicine and transform the way society responds to kids exposed to significant adverse childhood experiences, or ACEs, and toxic stress. CYW was formed to respond to an urgent public health issue. Early adversity harms the developing brains and bodies of children. We push towards our goal through three activities listed: advancing clinical practice, translating ACEs science, and building a movement. Our vision is to integrate ACEs screening into the pediatric appointment workflow and use a toxic stress framework to enhance the quality of patient care and health outcomes. The NPPC is a co-designed learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care and focused on the integration of ACEs screening and intervention into pediatric medical practice. Our goal is to advance dialogue, raise questions, push forward the fields of research and medicine, allow research to emerge from practice, disseminate findings widely to advance medical practice, and provide a network of resources and support around the science of ACEs, implementation of screening, and the development of integrated referral systems. This community gives members an opportunity to expand knowledge, build capacity, learn collaboratively, and shape the field of ACEs and toxic stress as it relates to pediatric medicine. Our hope is to leverage and showcase the expertise of NPPC members who are already screening and provide guidance, support, and resources to NPPC members who are working towards that goal. This project operates on two levels. At the broadest level, the NPPC is a virtual co-designed network of medical providers that are at various stages of readiness for implementing ACEs screening or integrating an ACEs and toxic stress framework into practice. This network is currently about 800 members strong and growing, and all members have access to our member website, which is where you can find the application for Cohort 2. ACEs are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or ACE study, conducted in 1998 by Drs. Vincent Folletti and Robert Anda. The study was a partnership between Kaiser Permanente and the U.S. Centers for Disease Control and Prevention. It was one of the largest investigations ever conducted to assess connections between early adversity and adult health. The study had over 17,000 participants who were primarily Caucasian and college educated. The study is the basis for the 10 core ACEs, often characterized in 3 categories: abuse, neglect, and household instability. They include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, where the child has witnessed violence against their mother, or there has been a separation from a caregiver due to incarceration, shifting parental relationships, or divorce. What the ACE study told us was striking. ACEs are incredibly common among the population, with over 2/3 of the adult population having experienced at least one ACE. We also have data that shows that nearly half of all children today have experienced at least one ACE, and that ACEs accumulate over childhood. And now I'm going to turn it over to my colleague, Lena, to talk about the pilot site program.
Hi, everyone. My name is Lena Singh. I'm the director of the National Pediatric Practice Community. So in addition to the NPPC virtual network that Molly described, and as part of our learning about the integration of ACEs screening in clinical settings, we have embarked on deeper engagement and learning partnerships with select medical practices around the country. And we call these our pilot sites. The pilot site program is truly a partnership. These are practices that have yet to adopt an ACEs screening protocol, and we provide tailored support, training, technical assistance, and clinical quality improvement coaching around all aspects of developing and implementing this protocol. So given that we view this partnership as a learning opportunity, we collect data on screening uptake and follow-up for each practice. We also share information and learnings with pilot sites from our members in the virtual network. So it truly is a co-designed two-way learning street, if you will. We truly hold up our pilot sites as pioneering practices that are modeling the feasibility and sustainability of screening for providers around the country. So given this focus on learning, we have clear learning objectives that help direct our work with our current and future pilot site cohorts. We want to identify the key drivers and best practices to implementing and sustaining ACEs screening in diverse clinical settings. We want to identify and learn how to overcome the common barriers to screening that we know about through tailored content, coaching, and our partnership with these practices. We want to facilitate opportunities for a robust understanding of what each clinic's journey to screening excuse me, looks like, and how these learnings can be translated into strategies for similar clinics. And lastly, we want to increase the number of clinics that are screening for ACEs. Excuse me, I have a little frog in my throat. So why become a pilot site? We know that implementing, from our experience at CYW and the NPPC, implementing screening can be complex. Providers have many questions about implementation, staff training, organizing referral systems, the value add of another screen. And while these are areas in which we are documenting learnings, we also have expertise, tools, and insights that can help your practice implement screening in an effective and efficient way. And we will provide support for each step in your process. As part of the pilot site, we bring you together with an expert coach who will help you create a plan to start screening and help you overcome barriers as you encounter them. The NPPC uses the lessons learned throughout this process to inform our own ability to coach other organizations that may be facing similar issues. And we hope that these broader lessons learned can be disseminated through the NPPC virtual network, webinars, and other trainings. We've created a robust training package of materials and other tools and resources for our pilot sites, which we will tailor for your practice and protocol. And lastly, we'll provide operational resources and guidance around how to build and pull screening reports from your electronic health record, ongoing data tracking, resources around coding and billing, and how to use this pilot to meet your quality improvement and other accreditation requirements. These are the 6 practices we partnered with for pilot site Cohort 1. We've worked with these practices for about the last year and a half. For this cohort, we were limited to practices in California and New York, but we hope to expand our geographic reach moving forward. La Clínica de la Raza is an FQHC. We're working with their clinic in Oakland, California. Zuckerberg SF General Hospital in San Francisco is screening in one of their multiple pediatric clinics. Kaiser Downey Medical Center is in the LA area. Marin Community Clinics is a federally qualified health center north of San Francisco. Santa Barbara Neighborhood Clinics is another FQHC in Santa Barbara, California. And the Institute for Family Health runs the school-based health centers in Harlem Children's Zone's charter schools in Harlem, New York. All 6 of these practices are now screening for ACEs. 5 out of the 6 have completed their 6-month pilot periods and are entering the sustainability phase of their project. And 3 clinics have spread from screening at 1 clinic to screening within multiple clinics in their institution. We've also trained multiple providers within each of these organizations, though not all were necessarily involved in the pilot project. And these 6 practices have screened almost 2,000 patients. We're documenting our learnings from these practices around the feasibility and sustainability of adopting ACEs screening in different settings through case studies, which will be released later this year. Here are some testimonials from 2 of our current pilot site partners. Dr. Mercy DeGangi, who is a pediatrician in Kaiser Permanente in the LA area, and Dr. Andrea Ruth and Nancy Tilley. Dr. Andrea Ruth is a pediatrician. Nancy Tilley is the COO of the Santa Barbara Neighborhood Clinics. So I'm sure you're all wondering about the process. What will you be doing? What do the pilot site activities look like? So participation as an NPPC pilot site will last for 1 year, consisting of planning, implementation, and sustainability phases, and practices will also participate in program evaluation. Once the 6 sites in this cohort have been chosen and notified, our team will work with you to schedule a virtual kickoff meeting. We look forward to bringing together all 6 practices to meet each other and the NPPC team, answer questions, and discuss next steps in the pilot site process. After the kickoff meeting, we'll work to set up individual planning calls with each practice to discuss your screening protocol, data and training needs, and schedule an in-person 2-day site visit, at which time we will finalize your protocol, train your staff and providers, finalize your data build and reporting system, and set a go-live date for screening. After this site visit, each practice will engage monthly with the NPPC Clinical Quality Improvement Coach, Ms. Carissa Luckett, for a tailored consultation, training, and technical assistance. Each practice in this cohort will adopt a screening protocol using the Pediatric ACEs and Relevant Life Events Screening Questionnaire, or the PEARLS questionnaire. And we will help you adapt your protocol in a way that's relevant for your site's delivery model and your patient population. Each practice will collect, analyze, and utilize data to ensure a deep level of learning about clinical transformation and the adoption of ACEs screening at your site. We also hope to have multiple opportunities for you to interact with the other pilot sites in this cohort to discuss your progress with the pilot, share challenges and learnings, and disseminate best practices. And lastly, we would like for you to participate in future learning in partnership with the NPPC, in future learning, innovation, and research opportunities with the Research and Innovation Network that we hope to build out in the coming year and beyond. And the goal of this network would be to surface questions from the field, to participate in ideation and peer information exchange, and to help develop and rapidly test products and services designed to address screening in medical practice. And now I will turn it back over to Molly to talk about the eligibility and application process for Cohort 2.
Great, thanks, Lena. Great, so for participant eligibility, so for those that are that would like to apply, so here's some things that we would like you to be eligible for. So that you are not currently screening, but are really enthusiastic about the about your screening process and are ready to go. You need to demonstrate that you have the resources to provide mental and behavioral health services for people who do screen positive for ACEs. We do want to make sure that you do have the capacity to start a screening program within the next few months, within really the 3 months of that kickoff meeting, and that includes robust EHR reporting. And then the capacity to use web-based meeting services. So that's really to meet with us, your coach, and also to meet with other members of the pilot site cohort to talk about best practices and how the program is going as well. Also, you'll need to commit to creating a reporting system. You'll see on the application process, we do ask about your EHR, you know, what EHR are you using, and how fast could you create new fields in there so that you can record the screenings that you're doing. We also need to make sure that there's enough administrative time for designated leaders to attend necessary meetings. As Lena mentioned, we will publish the findings from the pilot, so we do need to make sure that you are okay with the publishing of those findings. There is a timeline set forth in the agreement. We want to make sure everybody's online with that, and then agree to utilize the coaching and technical assistance provided. So we will ask you to put together a pilot site implementation team, and the members of that team are listed here. So you need a pediatrician champion, an engaged physician, a team lead who has the ability to act as a facilitator of the team, and this person will be the one to check in monthly with the NPPC coach. We need a data leader. As we've mentioned a few times, data is a really important part of this process, and so we do need somebody on this team who supports IT or supports your EHR and can be the person to make sure that you can keep track of those results as they go forward. And then an administrative lead to provide oversight and executive leadership. And one of the questions we got on the last presentation was whether these can be the same person. So we would like different people to fulfill each one of these roles. So I'll go over the application timeline. So the application has been available since last week. So it is available right now. And in a minute, I'll go over where it is on our website so you can access it. We are giving you about a month to fulfill the application. It's due on March 1st. We will interview a few sites, and that's about the second week in March. And then the first week in the first week in April, we will notify the pilot site selection group, and then we will do a kickoff around the second week in April. And that kickoff will be virtual, so don't think you'll have to start thinking about traveling. All right, so this is where to find the application. So you will need to become a member of the National Pediatric Practice Community in order to access the application. But don't worry, membership is free. So if you go to nppcaces.org, if you're already a member, you would just log in. If you're not a member, you can click on join and you can fill out the application survey. It doesn't take very long, I promise. Once you get into the site, you can go to what's called the Member Center, and then you go to pilot sites, and there is a sentence in there, and you can see it at the bottom. I've cut and pasted it from the website. It says to submit through the online application platform, and that will take you directly there. So we will be, like I said, we will be posting this webinar on our website within the next few days, and we will also include these slides as well, so you can see how to access that, the application. So from there, that concludes our presentation. If you have questions, we would love to answer them. I'll give everyone a few minutes to sort of collect their thoughts and start typing up their questions.
Somebody asked the question, can the pediatrician champion be a pediatric nurse practitioner? I'm the champion for our site in Arizona. Absolutely. We're really looking for a provider champion. And if that means an NP, for example, that's been the case with one of our current pilot sites, that would be fine. We're really looking for that provider champion who can really sustain and help us implement this project.
The next one is, do you have a sense of where you want to be across the nation? I don't think we have specific sites that we're thinking about, but I know we do want to have a diverse, geographically diverse group this time around. So we're looking at everything.
There's a question around being involved or having other educational grants that may be helpful or look negative. I think it would be helpful to get a little bit more information around what you are thinking about. This is a quality improvement project from our perspective. That being said, there are sites that we're currently working with that have gone through an IRB process and are looking at this more as a research study. But from our perspective, as the NPPC, this is a quality improvement initiative. So we will not be going through an IRB process with any of our sites.
Lena, this is Carissa. I just wanted to answer the question about MOC credits.
Yep, go ahead.
This project would absolutely work very well for an MOC for credit for the QI. We have not formally applied for that, but would certainly be willing to help anyone apply for that and help you meet those requirements through the American Academy of Pediatrics or whatever subgroup you may also be working with.
There's a question around if we have estimates for the number of hours each role requires, the four sort of roles that Molly outlined. I would say that, you know, the planning process, there is some time required, 1 to 2 planning calls with the NPPC team, and then setting time aside for the 2-day site visit. And that first day is really when we meet with the implementation team. It's usually a full day visit. And then the second day is when we usually hold the provider training. So that's 2 days. And then really, you know, once the screening goes live, monthly coaching calls usually take 30 minutes to an hour, and those happen once a month. So hopefully that gives you a sense of the time commitment. And we're happy to continue to have that conversation if folks are concerned about the time needed as part of this project.
I would also say, this is Carissa again, probably after the pilot is started and you begin implementation for the physician champion, it would be about 4 hours a month total, just between the calls and doing some follow-up with your team leads and data collection. On the data piece side, it depends on whether or not you can generate a report from your EHR or if you're going to need to manually tabulate and of course your patient volumes. But I would say about 4 to 6 hours there a month would be plenty of time.
There's a question around if there's travel, will costs be covered? Yes, absolutely. If we plan to have an in-person convening, we will be covering the cost of attending for at least 2 members from each pilot site. And those would be folks that are on the implementation team. So there's a couple questions here around very specific practices and the context. I would say that please feel free to reach out to me or Molly after the webinar if there's specific questions about your practice and the way that your practice is set up so that we can help address those questions. Another question about travel costs, which we addressed. Molly had discussed what factors will be used to determine who we bring on as pilot sites. Molly, do you want to go back to that slide and talk a little bit about the eligibility requirements?
So yeah, so these are the list of eligibility requirements. So really interest in screening, resources for mental and behavioral health, capacity to start a screening program, an EHR program that you can add fields to if need be, so that we can record how you're doing with the screening, capacity to use web-based webinar, just like you're using today, administrative time, consent to publishing findings, and then ability to adhere to the timeline, and then to really, commit to using the resources that we're providing you. So I know I went over that really fast. Again, these slides will be up in the next few days, so you can review them. And there's actually on where I was telling you where the application is, there's a whole web page there that goes over everything that I've gone over in this presentation as well. So all that information is on that web page if you need to refer to it.
There's a question. Oh, go ahead. Go ahead.
I was just going to say there was a question about a practice that has 2 providers currently screening. The pilot would be an ideal experience for you to spread that to your other 10 providers. That would be a great way to accomplish that, and clearly that would show you already have a great deal of interest and commitment to the screening. There's also a question about targeting high-risk families. The model that we use at the NPPC and Center for Youth Wellness is that really all children should be screened, ideally. In the pilot, we do recognize that it's typically better to start with a small subset, say age 7 well child visits, all children that are 7 years old that come in for a well child. But we are not typically focused on screening high-risk patients, as we know from the data that ACEs are much more common than we anticipate in a lot of our families.
And similarly, there's a question about minimum or maximum practice sizes. We're really open to, looking at your practice on a case-by-case basis in order to best understand the context of your particular delivery setting, the size of your patient population, and how your site might help us learn together around this issue. And so we are not setting sort of minimum practice size requirements for Cohort 2. And again, somebody asked another question about, having practices in 2 different places geographically. Again, if you can provide more information about that on the application, that will help us better understand your particular context and program. And we will definitely follow up if there are additional questions.
As far as the 2-city team, we certainly would be open to hearing more about that as well. There was a question from Allison Logan. That sounds very interesting. Let us know.
Carissa, there's a question around developing a template in their EHR and if there would be reimbursement.
Sure. I'm not sure if the question is referring to us providing additional pilot funds for building the template. The answer to that part is no. And otherwise, we have many practices that we've worked with that build this into their EHR. That is one of the sort of eligibility components that you would be able to build it into your EHR within 3 months. We have not seen any states add additional funding for the ACEs screening yet, but many states are in the process of approving legislation to address that. So I think also speaking to your provider, your insurance providers in your networks is something that we could help facilitate a conversation with. We've talked with some interested payers in the past as a part of one of our pilot sites. So I do think that that's fairly close down the road for additional funding.
There's a question around how many applicants we expect in this round. I think it's difficult to say at this moment, given that we just opened the application process last week. But as we mentioned, we hope to bring on 6 sites as part of this second cohort. And we had 6 sites that we worked with for cohort 1. There's also a question around preliminary data from cohort 1. As we mentioned, we have been collecting data from each one of our practices in our first cohort, and we hope to release case studies later this year that will share not only the data from our pilot sites around screening uptake and feasibility, but also insights, lessons learned, and what that practice's journey to implementing ACEs screening looked like. So very sort of comprehensive case studies for each of these practices.
And I'd like to add that the data that we are asking each pilot site to submit throughout the 6-month agreement is not a huge amount. We really will be looking primarily at 4 outcome measures: the percent of patients screened that were eligible in a given month, the percent that screened positive in a given month, and the percent that had an appropriate referral in a given month of the patients that were positive, and then the number or percent of patients that were eligible to be screened that refused. We may ask for a couple of other outcome measures, but those 4 are the primary drivers that we look at for success of implementation, and then success with the process with scoring and referrals.
There's a question here about being part of a large pediatric practice and concern that, adding screeners, there may be some issues with buy-in around that, and being part of a large hospital system. I think that we want to ensure a baseline level of readiness so that the screening pilot can get off the ground relatively quickly. For all of the practices in this second cohort. Again, we would be happy to have further discussion with you about your particular context and your delivery setting and what your current screening projects or programs look like and how this fits into what you're currently doing. But as Molly mentioned, we are looking for sort of a pretty robust baseline level of readiness so that we can get the pilot project off the ground pretty quickly. There's a question here about interest in doing work around data analytics related to other issues, chronic absences, behaviors, family engagement, etc. This would definitely be something that our research and innovation network could partner with you on. And I think that these are the kinds of questions that a lot of practices have. And so absolutely not necessarily as part of this pilot program, but as part of your broader scope of partnership with the NPPC and with the Center for Youth Wellness. These are absolutely the kinds of issues that we would like to address through our research and innovation network that I alluded to earlier. Somebody asked, I work in a network of 11 clinics. We're interested in starting to screen across the network. Would this pilot consider the network as a site, or is each clinic a separate site? So we would recommend starting with one practice and really sort of problem solving and implementing the screening in that single practice and determining and you know, working out some of the kinks around the protocol, etc., before you spread to additional practices within your institution. And that seems to be a model that's worked very well for our sites in Cohort 1. I don't know if you have anything to add to that, Carissa.
Yes, I would just say we've used that model very successfully with a couple of sites that have spread up to 5 other clinics in their network. We can tailor training in the beginning that might include all of the identified physician champions for each clinic in your network, but then go live in 1 or 2 clinics that may be very close in proximity or size, demographics, and then would talk with you and work with you down the road to have a sustainability and spread plan to the other clinics in your network. There's a question about what is an eligible patient. It's a great question. And typically we do screen patients. There have been some clinics that have also decided to screen parents in young infants, but primarily the tool is validated to screen the patient, so the pediatric patient. All of the tools are parent self-report for the child, plus there is an adolescent self-report. So the tools are broken down into key age groups. An eligible patient is going to be whomever we work with you to decide where you'd like to start. So if the protocol that we develop with you for your clinic says you want to screen 13-year-olds because you have a behavioral health specialist that has a great deal of expertise and likes to work with teenagers. So we might use screening with that age group to establish a good referral partnership with that behavioral health specialist. Or you might say you want to screen in early childhood to address more of the family resilience and protective factors in early childhood. So we will help you decide what's the best patient population to screen for your practice, and then that becomes the eligible patient. So there's a great deal of flexibility in that aspect.
And for those of you who have questions about the tool, the instrument that we'll be using for this cohort, please visit the NPPC website, so nppcaces.org, and you will see a frequently asked questions document about the PEARLS instrument, the questionnaire. So nppcaces.org, and almost the first thing you'll see will be that FAQ page. So please take a look if there's additional questions about the tool. Any other questions from folks?
While we're waiting, I'll just go over the, I'm going to go over the timeline once again. So the application is available now. It's going to be due March 1st, so just under a month. We will do some interviews, like I said, the week of March 11th, and then the first week in April, we'll notify the pilot sites of their eligibility to start their program. And then that second week in April, we'll probably do a kickoff meeting. So just wanted to kind of go over that one more time. It looks like we got one more question about the reading level of the screening tool.
So this screening tool, the Pearl screening tool, is developed as part of the Bay Area Research Consortium. This is a partnership to validate an ACEs screening tool and look at biomarkers of toxic stress. This is a partnership between the Center for Youth Wellness, UCSF, Children's Hospital, and the UCSF BioCore Bank at the School of Medicine and Pharmacy. So I think we can definitely find additional information for you about the pilot study where this tool was piloted at Children's Hospital in Oakland. The Pearls tool has been looked at for face validity and other types of validation. And so if you look at the FAQ document, it provides more information about that. And we can definitely have additional conversation with you about the reading level or the literacy level of the tool itself for your patient population. There's a question, is it critical to have behavioral or mental health staff embedded in the primary care practice? We absolutely suggest that you have referral resources to behavioral or mental health services. Those services do not necessarily need to be embedded in the practice itself. However, we recommend that you do have strong linkages to those services in your community, even if that doesn't exist at your particular practice, that there are other places where you can refer patients and families who are in need of more intensive therapeutic intervention.
I'd also like to add that as part of our findings from the initial pilot study was that there were a large number of resources needed that were not traditional behavioral health or mental health services. Things like what we would see now as a promotoro or a community health worker, families just trying to navigate financial resources, rides to appointments, parenting classes, stress reduction, nutrition, many of the things that we know can build resilience in families and children's life, even yoga. But we have found with 2 of our 6 original pilot sites the need or high use of a patient navigator or a care navigator, which was essentially a medical assistant that had some additional training that was provided both at the clinic and we were happy to provide as well in helping to connect patients and families with community resources. So we just really want to make sure that you do understand that not all patient families are going to need, even those that score positive, intensive behavioral health therapies. They may need a good bit of community resource assistance and help navigating that.
All right. Well, it looks like that's all the questions that we have for right now. As I've mentioned, if you have any further questions, feel free to reach out to myself or Lena, and we would be happy to answer your questions. And we will send a follow-up email with a link to this presentation, to the page that will contain the video of this presentation as well as these slides. So we'll send that out within the next few days. All right, thank you very much, and hope you all have a wonderful rest of the day.
Thank you.
Thank you.